Hello and welcome to Essentials of Athletic Injury Management, 10th edition. In this chapter, we'll be going over chapter 19, and we'll be talking about the elbow, wrist, and hand. This is a pretty wide and comprehensive chapter. There's a lot of different injuries to go through, so you're going to have to spend a little bit more time on each of the relevant sections. I'll try to do my best to emphasize things that you'll be more likely to see when you're in practice. So we're going to start with the elbow, and again, we're going to do our who, what, when, where, how, and why of the history. Again, looking at anything in the past, what was the mechanism? How did you hurt it? Where does it hurt? What kind of pain is it? How painful is it? We get any relevant sounds or sensations, and has there been any swelling or dysfunction that went along with this? If you've treated it, if so, how, and what made it better? Observations, things that we're looking for is we're always looking for deformities and swelling. We're always comparing bilaterally. How are they carrying the arm or the elbow? Are they keeping it in a flex position? Are they keeping it in an extended position? What position is it in? Palpation, again, remember we always start with bony palpation. We start on the epicondyles, or the outside and inside parts of the bone. And to palpate those, and then we're going to look at the olecranon, which is the tip of the elbow, and then we're going to palpate aspects of the humerus and as well as the radius and ulna. From there, we'll move on to the soft tissue. We can start with the ligamentous structures. Again, we're looking at the elbow on the inside and outside, the UCL, the ulnar collateral ligament. In particular, especially in throwing type athletes. We're also going to we can take a look at the muscular tendinous junctions. We're looking like biceps tendon, flexor carpes, etc. Prevention of elbow wrist injuries. Again, these are typically vulnerable to both acute and chronic type injuries. Ironically enough, we talked in this last unit about the shoulder. Shoulder injuries oftentimes transfer themselves down to the elbow. If someone's complaining of elbow pain, especially chronically, we really want to do a good examination of the shoulder, because a lot of times, especially in throwing athletes, you'll change your arm slot to protect your shoulder, and in doing so, you'll put more pressure on your elbows. So we always want to make sure we're checking the shoulder along with the elbow. In the event that you're in a contact or collision type sport, we may want to look at protective gear of some sort to protect the elbows. Again, to avoid chronic injury, we want to limit repetitions. Again, we may want to be careful with specialization in sport and things of that nature. We want to have different types of biomechanical force and allow appropriate rest. We really want to emphasize those proper mechanics. Again, I emphasized already about the role of the shoulder and how that impacts the elbow. We also want to think about the age group and the type of things they're doing. We look at youth athletes, for example. We go back to those mechanics and or the types of pitches and things that they throw. What impact does that have on a developing body? Special tests, again, this is probably something that we're not going to do a lot with coaches, but we certainly can do kind of a manual muscle or motion type test, passive range of motion, resistive range of motion. And if with the lateral and medial epicondyle test, this is basically saying inflammation of the inside or outside of the elbow, sometimes known as tennis elbow or little leaguer's elbow. We put them into that flexed type position. There is a picture of this in your book on how to conduct this test, and that is on page 309, and that's figure 19.6. And you're basically in that flexed position, flexed elbow position. You are resisting either extension or flexion of the wrist. Extension is the lateral epicondyle. Flexion is the medial epicondyle. Any pain in the inside or outside of the elbow with one of those would denote epicondylitis of some sort. And again, we already talked about doing passive and active range of motions at the elbow. Pronation, supination, which is basically turning the thumb in and out, and then as well as elbow flexion and extension. Recognition of injuries. We want to look at things like olecranon bursitis. Olecranon bursitis is not any different than when we talked about before. With bursitis on the knee, this is going to be water on the elbow. This is something that I've seen quite frequently. Again, usually due to a direct blow. It'll look like jelly or water on the elbow. It's usually pretty tender, very, very tender, painful. It's red, it's swollen. So definitely want to differentiate from active infection. But typically speaking, this is fairly benign, but we want to make sure that we are protecting the area, that we're ricing the area and trying to avoid any additional blows to that area. Elbow sprains, again, usually the MCL or the inside of the elbow is the most commonly sprained. This is kind of Fuchs type injuries and or someone falling on top of your arm. So typically there's pain on the inside of the elbow. This is going to go along with our kind of grade 1, 2, 3 type of grading scale here. Where there is a conservative treatment with it. We're going to rice it. We're going to keep the elbow in a flex position. They're usually going to feel more comfortable in this position. They generally present in this position. And then again, we'll have our medical professionals or our therapists and our athletic trainers work with us on working through our various range of motion and rehabilitative activities. If the MCL is unstable, like a grade 3 or a grade 2 plus, we're probably looking at some sort of surgery, and many folks, especially in the area of basal, are probably familiar with a procedure called the Tommy John surgery. Lateral epicondylitis, tennis elbow, again, a very common injury. See it in the racket type sports, but not only. You're going to have, again, pain with your elbow inflection. You have pain in that extension, and it's just a repetitive type injury, chronic repetitive use. They typically are going to describe kind of an aching type of pain. It's usually going to be point tender. Again, pain will worsen over time, and in those, basically their backhand is what's going to hurt. Another thing that we can do along with the treatment on this, and other than rice, NSAIDs, and kind of cross friction massage type activities, we also can modify our equipment. We can look at going with a little bit larger head, as well as increasing our grip size. We can do this with the medial epicondylitis as well, but typically on the racket sports it's lateral epicondylitis, so we can increase the diameter of the handle and make sure we have a little bit larger head on the racket. A neoprene sleeve, just keeping it warm, can be helpful. Medial epicondylitis, on the other hand, is going to have just a slightly different treatment in terms of sleeving or bracing. Medial epicondylitis, this is the exact opposite of the lateral epicondylitis. This would be like your forehand, and or with our throwing or striking athletes, it's just that basically your arm coming forward, it puts that torque, or horizontally adducting, it puts that torque on the inside of the elbow. Again, it's repetitive in nature, but because it is an itis, it is an inflammatory condition. They're going to again describe point tenderness. We usually have in that bent elbow position, again, wrist flexion is going to be painful. And again, we can change the size of the racket handle with these folks too. Now, I did tell you the bracing and or sleeving would be a little different. We talked about on the lateral epicondylitis about wearing an elbow sleeve. We also, for the medial epicondylitis, we can use a curvilinear brace, which there's a picture of a curvilinear or counterforce brace on page 310 on figure 19.9. It's basically, sometimes you'll see these on bowlers. That's not unusual. And it's a lot like the patellar strapping or bracing that we did for jumper's knee. We do this very similarly on the upper forearm for the medial epicondylitis, and it can give some relief for the participant. Elbow osteochondritis dissecans. This is bony chipping or loose bodies within the joint. I haven't seen this a lot personally. It's no different than when we talked about it in the knee, but people are typically going to have pain. They're going to have descriptions of locking and popping, and so this would be a suggestion that there's some sort of loose body in there. And again, this is something we'd need to refer to a physician. We want to do so right away, just because the more you grind it up in there, the more likely you are to develop osteoarthritis. Ulnar nerve injuries, again, these aren't entirely unusual. We're looking on the inside of the arm. This is folks who maybe they're doing some sort of a power clean, maybe a snatch, something up overhead. Maybe they're a throwing athlete, and whenever they get that kind of torque on the elbow. They describe of kind of like a burning, shooting, and a numbness in in their forearm and or their hand. They may even have kind of a pop type of sensation followed by the numbness and tingling, where the ulnar nerve is actually coming out of its groove and creating the paresthesia. And so again, typically in the fourth and fifth fingers, the ring finger and the pinky of the hand, you'll feel that numbness and tingling. And so this is something that you're going to want to avoid aggravation if you can. So avoiding the activities that cause that. We're going to do conservative treatment, again, our RICE methodology. But in some cases, if this is chronic, especially in the case of subluxation, then it may warrant surgery to try to fixate that ulnar nerve in that cubital fossa. Dislocation of the elbow, again, not something you see a whole lot, but it really takes a pretty traumatic high velocity type incident. You can see a picture of the mechanism on page 311 in figure 1910, picture A there, kind of falling backward and or outward on a bent elbow. And then you'll see this a lot too, like in football and that, where there's a kind of a pile up where someone falls on top of you and that force just drives the humerus down and then bringing and popping the olecranon out. Again, this is something that's an emergency. You're going to want to check vascular status and neurological status. Can they feel? Is blood returning? Do they have a pulse? Capillary refill, that kind of stuff. Make sure we're calling EMS. And again, we're splinting them in the position that they're found. Fractures of the elbow, this is actually very, very similar to what we just talked about with the dislocation. Happens for a variety of reasons. Again, you're going to have point tenderness, pain, spasm, and we're going to want to split them in the position they're found, and we're going to want to get them to a physician. Moving down from the elbow to the forearm, again, our history and observation palpation is very similar. Who, what, when, where, how, why. Getting a description of that pain. Again, is this acute? Is this chronic? And get an idea of what you might be dealing with here. Again, we always inspect for visual deformities and changes in the skin and looking for swelling. Palpation is exactly the same. We're going to start with bony and work our way to soft tissue. Again, the forearm is particularly susceptible to fractures, especially in falls on outstretched hands. And we're going to talk about a couple of those type of fractures here in a second. I'm not going to spend a lot of time on contusion. We've talked about this multiple times through this series, but we're going to treat our contusions very much the same that we've treated others. And again, not as typical that you're going to see issues with the myositis ossificans. However, it is possible, and keep an eye on that. How do we use forearm strains? This is, again, not any different than any other muscular strain. It's going to be your extenders or your contractors. So basically on the inside of the arm or the outside of the arm, probably a little bit more typical on the inside of the arm or the medial side of the arm or the palmar side of the arm. And it's going to go with your typical grade 1, 2, and 3. Forearm fractures, again, this is usually direct blows or fall on the outside arm. We can fracture the ulna, the radius, or both. Again, usually there's an audible crack or a pop with disability and a significant pain. We want to splint and immobilize them in the position found, and we're going to want to immediately send them to a physician. Again, we're looking usually in the area or the range of 4 to 8 weeks on any fracture. But we want to talk specifically about this fracture, the Colles fracture. Again, this is that Fuchs type injury falling on the radius. This is the most common forearm fracture. It's on the typically on the radial side. Again, they fall on that extended wrist. There's displacement slightly posterior. It's sometimes called a dinner fork deformity, and I thought there was a picture of this. Okay, there's a picture on page 315. If you take a look at that on figure 1914, is on the upper left-hand corner of the book, and you'll see where that Colles fracture is right there on that distal end of the radius. Again, there's usually a visible deformity, a lot of pain, a lot of sweat. They'll end up with a lot of swelling, and we're going to want to get a cold compress, splint, refer to a physician. If they're splinted, we always check for vascular status, and then we'll send them to a physician for a subsequent treatment, a diagnosis and treatment. Hand and wrist, I'm going to spend a particular time on a couple particular fractures and or dislocations in the wrist, and then I'm going to spend a little time on finger deformities. I'm not going to spend a lot of time here on the history. We've talked about history, observation, and palpation. On observation, we can just look at, again, we're going to go back to kind of maybe some of these finger deformities when I talk about it. And then again, palpation is really easy to palpate on the wrist and hand because we aren't dealing with a whole lot of musculature. It's predominantly just the tendinous structures from the forearm in the hand. And so we'll talk about, we want to do a good bony palpation. Again, always remember we start away from the injury and work towards it. Where sprains are common, again, we kind of fall onto the wrist. We want to rule out fracture. In this case, a lot of times it's very difficult to rule out a fracture. There'll be pain and swelling, not any different than a fracture. So again, probably our primary mechanism, especially as a coach for differentiating between a wrist sprain and a fracture, is referral to a physician or an athletic trainer for appropriate determination. We're always going to, if we can't rule out a fracture or we think it's a sprain, we're always going to want to immobilize this and again, send them off for a referral. If it ends up being a wrist sprain and the pain is managed, the swelling is managed, and they have some range of motion, they probably are still going to want to limit some of that range of motion. So prophylactic bracing or taping may be appropriate, and we learned this technique in class. Wrist tendonitis, again, this is just a chronic version. This is repetitive movement at the wrist. It can happen for various reasons. Again, this is not unusual in racket type sports where you're doing a lot of flexion and extension of the wrist. And so you'll end up with kind of that crepitus feeling like the other tendinopathies that we talked about, that dull ache, particularly bad at the beginning of activity, maybe gets a little bit better as you get warmed up and then hurts again at the end. We're going to treat this conservatively with rest and NSAIDs as needed. You can wrist splint if needed, but again, I would consult a physician for that. Carpal tunnel syndrome, not something you see a lot with younger athletes. You may see it more with older folks, especially if you have folks that are recreational athletes, maybe in their job. They do quite a bit of work in wrist flexion, or if you have someone that spends a lot of time on a computer, but you can end up with this median nerve inflammation. And so the biggest way to tell this is to typically have numbness and tingling in the middle of the hand and weakness in the thumb. There's a thing called a Phelan's test where you basically, if you think about the prayer position, you actually put them in the exact opposite position. So you put the hands and the fingers downward and you press them together and hold them together for about a minute. If that causes numbness and tingling, that's a positive sign for carpal tunnel syndrome. But it's usually conservative management with RICE and NSAIDs. A physician may decide that if this is ongoing and it can't be conservatively treated, they may do a steroid injection, and or if needed, they can do a surgical release of the area and kind of basically loosen up that tunnel to allow the nerve to have a little bit more breathing space, so to speak. Scaphoid fracture. Now, this is one of those fractures that I really want to talk about because it's important. These folks are going to fall on an outstretched hand. They're going to have a pain in the wrist and the base of the thumb. Typically speaking, if you take your hand and you kind of spread your fingers out as wide as you can, right, making your hand as big as you can, you're going to notice on your thumb, you'll see two little tendons pop out. And right in between those two tendons is called a snuff box. And if you have someone that's fallen on an outstretched hand and they have pain in that area, in particular when you touch it, you absolutely have to send them for x-rays to the doctor. This can fracture. That scaphoid bone can fracture. It's also known as a navicular. It can fracture, and when it does, it has a really poor blood supply. And if it's fractured and you don't get them referred, that bone can die, and they're not going to get it back, and they're going to have dysfunction in that hand and wrist. So again, if they fall on that hand, they have pain in the wrist and or base of the thumb, when you spread that hand out and in between and in that snuff box, they have tenderness, you send them. Maybe nothing, but if you catch a scaphoid fracture, that's absolutely key. Hamate fractures probably don't see quite as much. Again, say Fuchs type injury falling on that hand. They'll have wrist pain and weakness. They may even, again, sometimes they may have numbness and tingling or weakness due to that ulnar nerve compression with that fifth. You can find the bones, including the scaphoid, on page 315 in figure 1915. You'll note the hamate is on the other side and slightly distal or closer to the fingertips than the scaphoid is. A wrist ganglion, again, there's a picture or a depiction of a wrist ganglion in your textbook. If you look at page, oh, by the way, that anatomical snuff box is on page 319, figure 1918. You can see where that anatomical snuff box is. But the ganglion cyst picture is on 320 on figure 1919. It's basically just a bump, a round bump. It's like if you palpate it and it's on top of the wrist, it almost feels like there's a lima bean in there. It's the best way I can describe it. It has a clear round border and it kind of can move around a little bit, but then when you let go, it's because it's fixated to the connective tissues, it'll kind of go right back to where it is. These folks usually, they see the bump, and usually the bump is it's more of a cosmetic thing than anything. Every once in a while they'll have discomfort and pain there, but with use it might increase a little bit. But typically you don't see a lot of dysfunction with a ganglion cyst. With the care, typically we want to use catch it early, use a pressure type pad to push on it, try to basically encourage the body to break it down and push it out. The old-fashioned way back in the day was to literally smack it with a book or Bible really hard and basically rupture the cyst and let the body kind of pick it back up. But the treatment these days is that padding, and or the doctor will go in and aspirate it or drain it with a needle. And in some cases they'll excise it or take it out. Fifth, metacarpal fracture. Again, a very, very common fracture in the hand. There's a picture of it on figure 1920 on page 320 of your book. They call it a boxer's fracture because it's most commonly seen when you punch or hit something. I've seen this a lot, including myself, in athletes who maybe say punch a wall or something because they're frustrated. So they'll bust that. There a lot of times they'll have pain, they'll have swelling. If you palpate it, sometimes you can actually feel that step off or deformity, or you'll feel like kind of this crunching when you make a fist. So this is a classic sign of a boxer's fracture. They obviously need to be sent to a physician. You're going to splint them in the position found. Go back to that SAM splint we learned to use before, that Coke bottle position where you roll the SAM splint, or use an ACE wrap, place it in their hand, then splint the forearm. That's how we're going to split a metacarpal fracture in the hand. Again, 4 to 6 or 4 to 8 weeks or so on this. In some cases, it warrants fixation or pinning, but again, the physician will make that determination. Mallet finger is depicted on page 320 and figure 1920. Again, basically the tip of the finger, you rupture that extensor tendon, and so you cannot extend the finger, so it kind of gets stuck in a bent position at the DIP. A lot of times you'll have a chip fracture with this, or an avulsion fracture of the bone. So even when they try to move the finger, you might feel a little bit of a click, 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 click with it, and or feel that or see a little bit of a bump on the end of the finger where that chip fracture has taken place. We're going to want to splint them in extension and refer them to a physician. A boutonniere deformity is depicted on page 321. You'll see that in figure 1924. That's in picture A. And that is a PIP dysfunction. So it's kind of held into flexion. So at the PIP joint versus the DIP joint. Usually, this is an avulsion type of injury, and then you'll have that pain at that joint. They cannot extend the finger, and we need to make sure that we get them. Again, we treat them like we treat it like a fracture. Cold application, splint them into extension. If we don't do this, that finger will permanently be stuck in that flexed or that boutonniere deformity type position. A jersey finger. Maybe not the best picture in the world, but you can be seen on page 321 and figure 1925. This is exact opposite of the mallet finger because it's a rupture of the flexor side. So whereas the mallet finger was a rupture of the extensor side. So jersey finger is a rupture of the flexor side. It typically happens in the ring finger when you try to grab a jersey. The finger gets wrapped up in the jersey, and then you rupture that flexor tendon. It's at you cannot flex at the DIP or the tip of your finger. You cannot flex. It stays in that extensor position. And the difference between this one and the mallet finger is that it's going to have to be surgically repaired. There's a ton of tension in your flexor tendons, and so when that ruptures, it's going to pull back on you. It's going to kind of window shade on you and roll up just a little bit, especially if it's a complete rupture. And so this is going to result in a surgery. Gamekeeper's thumb. This is a sprain of the UCL ligament on the metacarpal phalangeal joint of the thumb, and so a lot of times you'll see this with like maybe skiers, folks that do like slalom, for example. You end up with this kind of gamekeeper's thumb. You get pain, tenderness, and swelling over the medial aspect of the thumb, again at that metacarpal phalangeal joint or the base of the thumb. Again, if you want to do immediate follow-up, make sure that you check this out with an orthopedist or physician. Make sure we rule out fracture in this case, and then they're gonna split and stabilize the thumb. Collateral ligament sprains. You're going to see this at the DIP. Typically at the DIP or the PIP joints, so basically at the knuckles of the fingers. And this is basically a jammed finger, typically speaking, or again, sometimes it's falling on a hand or something, but typically jammed fingers where either the inside or the outside of the joint line at the knuckles is compromised. And so when you can kind of like what we did for MCL and LCL on the knee, you can do these kind of valgus or varus tests, and if you get opening at that joint, it may represent a collateral ligament sprain, and you grade these just like, again, the rest, 1, 2, and 3. But we're going to want to splint and support these and refer them to a physician to rule out fracture. Dislocation of phalanges, again, this is pretty common. See this all the time, especially in ball type sports where there's passing, say football and basketball. I've seen this. Again, the ball hits the tip of the finger, usually forces the first or second phalanx back over top of the other knuckle. This is called a dorsal dislocation. Is probably the one most commonly seen. And then this needs to be reduced. It can be an open or closed dislocation. Open basically means that the bone is popped out. There's actually a picture of a thumb open dislocation on figure 1926 on page 322. This is a pretty forceful injury, and obviously we're going to have some wound management to go along with this one. But again, as a coach, we're not doing the reduction. We're not putting it back in place. So we're going to refer them to a physician for this. Phalanx fracture, again, very, very common. It can be a crushing injury. It can be hit on the tip of the hand by a ball. Lots of different, again, a lot of times fingers are stepped on. We need to make sure we differentiate this from the dislocation and the ligament sprain. Again, this is something that a physician is going to have to do. So we're going to treat them conservatively and refer them to a physician. Subungual hematoma, we've seen these on the foot before. That's blood under the fingertip, not unlike the toenail. If you get that blood accumulation under there, you need to get it out. You can use the nail drill, or as I recommended before, if the medical professional wants to utilize a cauterizer or something like that to get that blood out from underneath the nail, this is advised. Otherwise, they will lose the nail due to that accumulation of blood.